2019, and we'll get started. The image in the New England Journal concerns a 73-year-old woman that presents with this umbilical nodule. As we can see, it's an older lady, and the nodule is about 2 centimeters in diameter. It looks reddish, inflamed, it's painful, and the differential diagnoses we're given are keloid formation, an umbilical hernia, pyoderma gangrenosum, pyogenic granuloma, or Sister Mary Joseph's nodule. This is a Sister Mary Joseph's nodule. And what this is a metastasis from some sort of intra-abdominal tumor that sneaks up the embryological urachus and sets up shop in the umbilicus. And this lesion is named after a Catholic nun who was the OR nurse for Dr. William Mayo at the Mayo-Clinic. And this can occur with a variety of intra-abdominal tumors, most commonly with ovarian carcinomas. And that's what that is. These other differential diagnoses don't even come close. Here are some other examples. Sister Mary Joseph nodule. Proposed mechanism for the spread of cancer cells to the umbilicus, transperitoneal spread via the lymphatics, etc., along the falciform ligament. Sister Mary Joseph, again, was a Catholic nun and the surgical assistant of Dr. William J. Mayo at the Mayo Clinic. And he published a little paper about this in 1928. And Sister Mary received her due in 1949. But this is a classical lesion, and once you've seen one of these, you don't forget it, and the other things don't play any role. Umbilical hernias occur in newborns, sometimes in young children if they're ignored at birth. They should be operated upon, something entirely different. They're not an inflammatory lesion. Keloid formation involves changes in connective tissue after scarring, much more common in Black people than Caucasians. Probably there's some abnormal growth involved here. To my knowledge, the etiology of keloids is not yet clear. They're a major clinical problem because of recurrence when excised. The issue in the New England Journal concerns the training of house staff physicians. You'll recall that beginning doctors in the United States are called interns. The reason was that in earlier times, they were indeed internal. They lived in the hospital. And if they survived the first year, they became residents and then lived in the hospital relatively permanently. Medical students who could go home in the evenings were called externs. That's where these terms come from. Now, when I graduated from medical school in 1968, the average working week for interns and residents was over 100 hours a week. And we were on call every other or every third night. That meant showing up at the hospital at 7 o'clock in the morning, staying through the subsequent night, and staying through the following day until about 5 o'clock in the afternoon when we were allowed to go home. That would be a 36-hour shift. And if you do the 3 or 4 of those a week, you easily come up to 100 hours a week. Now, this all changed in 1984, and the entire training programs in the United States were radically changed, and one woman was responsible for this change, and her name was Libby Zion, and she did all this single-handedly merely because she died. She died in a New York hospital. The story was as follows. She was a student, unhappy, saw various doctors, was treated with various drugs for depression. She received imipramine, flurazepam, diazepam, also tetracycline and erythromycin, and she received also phenelzine, which is a monoamine oxidase inhibitor. She became ill and came to the emergency room had an axillary temperature of 42 degrees, had an elevated white count, was fairly incoherent and quite uncooperative, and the intern and the resident taking care of her received an order, a suggestion over the telephone, and applied 25 milligrams of meperidine. Meperidine, called pethidine in Europe, is actually a German opiate that was synthesized in 1916 because of the British naval blockade, which meant that Germany couldn't import any morphine-related products, and made several synthetic opioids that concern us to this day. After the 25 milligrams of meperidine were given, Libby Zion got much worse, and several hours later developed cardiac arrest and could not be resuscitated. A medical examiner considered evidence of cocaine use, which is not ruled out, might have played a role in her death, don't know. The year was 1982. A grand jury was convened because Libby Zion's father was a prominent journalist that worked for the New York Times, and the grand jury investigated the case. They made several determinations in their investigation. They observed that Libby Zion had never been examined by an attending physician. That would be Oberarzt in German. The second was that the physicians taking care of her had been on duty for about 36 hours and were probably tired. I'm sure they were tired. This episode took place in the middle of the night, and the grand jury made the recommendation that house staff working conditions should be controlled so that 36-hour shifts would no longer be necessary. They also observed that the order to determine this treatment was given by an attending physician who didn't come into the hospital to examine the patient, but the order was administered by telephone only. The grand jury also observed that the physician's desk reference, same as Rote Liste in Germany, indicated that phenelzine was a contraindication for the administration of meperidine. We'll look at that in a moment. And this case resulted in a radical change in the way that physicians in training are trained in the United States. First of all, it also determined that physicians in training are basically students, and they're there to learn material and procedures, etc., so that they can become competent physicians. Now, administrations commonly consider a doctor as a doctor as a doctor, but an intern is not the same as a resident, and a resident is not the same as an attending physician or an Oberarzt. And these distinctions have to be met, and attending physicians now have to be responsible basically for the patient's care, and each patient has to be examined personally by an attending physician in the United States every day. Now, the Greater New York Hospital Association determined that to implement these new regulations would cost the city of New York $203 million, which it probably did. Let's look at some of the issues in this case. Monoamine oxidase inhibitors are hopefully not administered very commonly anymore. Monoamine oxidase is an enzyme inside neural cells, but also present in other organs, including the liver. And the job of monoamine oxidase is to catabolize monoamines, including catecholamines, serotonin, and small molecules of this type. So monoamine oxidase inhibitors work by blocking this catabolism of monoamines so that the concentrations of norepinephrine, epinephrine, serotonin, dopamine, etc. are higher, which ameliorates depression. Now, problems with monoamine oxidase inhibitors were known when I was in medical school. For instance, if you eat the wrong kind of cheese that contains a lot of tyramine, there's a marked increase in blood pressure, which can cause stroke. And interactions between monoamine oxidase inhibitors and a whole variety of medications was already known. What wasn't known at that time is the role that serotonin plays in these syndromes. And for a variety of drug interactions, not only monoamine oxidase inhibitors and meperidine, but a variety of drug interactions can lead to the serotonin release syndrome, which results in tachycardia, sweating, nausea, vomiting, tachypnea, akathesias, hallucinations, tremor, myoclonus, seizures, and death. And this syndrome has subsequently been well delineated. Now, the studies in the New England Journal concern not the hours that physicians, well, let's back up a step. The physicians taking care of Libby Zion were surely tired, but Libby Zion's death was not because the physicians were tired. The cause of Libby Zion's death was that the physicians were not supervised properly and were stupid. Whether or not they were tired is irrelevant to the discussion, but the law has been fixated on the idea that physicians who are tired might make inappropriate decisions. So the working hours in the United States were cut from over 100 hours a week, or basically not counted, to no more than 80 hours a week. And physicians are not allowed to perform shifts that are longer than 24 hours, whereas 36 hours used to be routine. Now, sometimes because of holidays and religious celebrations and who knows what, it would be helpful for training programs if at least the shift length were somewhat flexible to account for these confounding variables. So in the United States, they actually tested the idea that a flexible program in terms of shift length would be no worse than the standard shift mechanism that's in place today. So what was done in this study is training programs were randomized to a flexible arrangement of duty hours compared to a rigid standard arrangement of duty hours, although the total number of duty hours were not different. And the first thing that was examined was, does this do the patients any harm? So these training programs were randomized. Tremendous amount of effort going into this study with administrative details that's almost incomprehensible how they did this, but this is what they did. So first of all, we look at the patients, and we're talking about 61,000 patients here and 60,000 patients here and 70,000 patients here. In other words, a lot of patients. And people that are in the hospital are generally my age, so the patients are older. Men and women are equally distributed, and the racial compositions of these patients were as what is observed in training programs in the United States. The diseases that the patients had, heart failure, diabetes, pulmonary disease, renal failure, peripheral vascular disease, etc., was equally distributed amongst the groups. Then the medical conditions, we can look at more detail here. And these patients were sick internal medicine patients. These are not surgical patients. These are internal medicine patients and with some neurological disorders mixed in. But what we see here is that the patient safety outcomes were no different if the physicians were operating under the standard rules or more flexible rules with change in their working hours, although the total working hours per week were not different. And so we can look at these safety outcomes in terms of these forest plots here, testing the non-inferiority of one type of shift compared to the other, and there was no significant difference. So we can, at least from the patient standpoint, conclude that whether or not the house staff physicians undergo flexible shifts or rigid shifts doesn't seem to influence patient care. And the authors draw attention to the Libby Zion case that was responsible for ending the very long shifts that used to be routine before 1984. And then in the next study, same patients, same doctors. Now they, instead of examining the patients, they examined the doctors. And they supplied the patients with actigraphs. These are devices somewhat similar to Apple Watch does this also, that can determine whether or not the physicians are asleep or awake. And the idea here is, does this flexible shift routine alter the amount of sleep that the doctors get so that they might be compromised in their decision making? Although we've already seen the fact that the patient care was no different. So this was done here. And so the mean hours of sleep, whether or not you use the Karolinska score or some other score, or then confirm this with actigraphy, this was all done, showed that the doctors slept as well in the flexible programs as in the standard programs. This is amazing. And you can look at the shift length. The flexible shifts are a little longer, but sometimes they're a little shorter compared to the standard shift, although the total amount of hours worked was no different. Although if we look here, the percent of interns sleeping was no different in the groups. I think that all this business is nice. Probably doesn't concern us too much, because the working hours in Europe are only 49 hours instead of 80 hours, and that's why the routine training program in Germany is 8 years instead of 3.5 years. Interestingly enough, the German physicians in training have the strongest union that I've ever run into, called the Marburger Bund. And the Marburger Bund is always concerned about money. I've never seen that they've been concerned about either patient care, how much the interns sleep, or how much they learn. Perhaps they should review the Libby Zion case. The next topic in the New England Journal is Ebola fever. And this is a severe infectious disease that involves subequatorial Africa. This is a single-stranded RNA virus that causes a whole variety of symptoms that are shown in this graphical display here. It has a relatively high morbidity and mortality, and it's a major problem in Nigeria and Zaire and countries of this nature. Now, the reservoir for Ebola virus is, in German, the flying dog, but in English we say flying foxes. What these are fruit bats. They're about the size of small dogs. They don't weigh quite as much because they're much lighter. They're called flying foxes in English, or fruit bats. Those are the reservoirs for Ebola virus. Now, Ebola virus is extremely contagious, and the spread from one person to another concerns direct contact, fomites, smear infection, bodily fluids, etc. Now, in this study, the symptoms and clinical consequences of Ebola virus were studied in a controlled fashion. What these investigators did is they found 966 antibody-positive Ebola virus patients that survived, and compared these with 2,350 antibody-negative close contacts that didn't get Ebola virus. And they followed these two groups for a number of years. And what we see here is that the groups that actually had Ebola, in red, these are the contacts, they had antibody concentrations according to survivor status, whereas these are the survivors, these are the patients that didn't make it, and the contacts did not have antibody and did not have RNA testing that was positive for Ebola virus. And what we see here is that the symptoms of the patients are fairly similar to the graphic that I showed you, except that interestingly enough, urinary frequency is high on the list. And the other things, headache, fatigue, muscle pain, memory loss, joint pain, chest pain, cough, rash, eye changes, etc., or even progressing to blindness occurred in the frequencies shown here. And if we can look at this new symptoms, people that have never had this before, comparing the survivors to the controls, the survivors of Ebola virus had these symptoms, whereas the controls did not. That's not so surprising. But testing, one of the reservoirs for Ebola virus is similar to Zika virus, and that's human semen. And the amount of time that had to regress before RNA testing in the semen samples from these obviously male patients spread out until about 3 years. Now, whether or not they still can transmit Ebola virus this far out with these numbers of Ebola virus copies, I'm not certain, or if the Ebola virus has been attenuated because of antibodies that the patients developed, I also don't know. But it takes a long time for Ebola virus to disappear from the body. So high burden of symptoms and survivors, and some close contacts also had symptoms, so it's important to evaluate a control population. And what we see here in this little graphic and this paragraph in German is that there are 5 different strains of Ebola virus. Ebola virus is related to Marburg virus, but not too close. And these strains of Ebola virus differ in their clinical severity, so that the Ebola virus that you get in Zaire is not the same as the one that you get on the Ivory Coast or in Sudan or even resident in the United States. There were several patients. The next topic in the New England Journal is actinic keratosis. These are hard, flaky skin changes that occur in sunlight-exposed areas in Caucasian patients, and they're important because they're pre-malignant. These lesions continue to grow, and some turn into squamous cell carcinomas and cause a fairly aggressive form of skin cancer, much worse than basal cell carcinomas if you're familiar with these things. And the question is, particularly for people that live in Australia and in very sunny areas of the United States or other places, is how can we get rid of these lesions? And so a randomized control trial was conducted to see what treatment is best. And the treatments that are applied are 5-fluorouracil cream. That's one treatment. Another treatment is imiquimod. I had to look what that is, and this is an antiviral agent that's used for condylomata and basal cell carcinoma, and also is supposed to be effective in actinic keratoses. The next treatment is abbreviated MALPOT, and it's a treatment that involves a photodynamic kind of therapy. And the 5th treatment is ingenol. And ingenol is actually an alkaloid that's acquired from this plant that's also supposed to be effective against actinic keratosis. So this is a fairly complicated trial because the patients had to be recruited, then randomized to their treatments. They're observed at 1 month, 3 months, and thereafter. Whether the treatment was a success or a failure is noted. And if the treatment was a failure, then a retreatment of the regimen was applied before one decided 12 months later which compound or which treatment was ahead. So that was the study. And 5-fluorouracil cream won hands down and beat all the other treatments by a goodly margin. So we can conclude from this study, since the adverse events were trivial and none of the adverse events listed here were actually attributed to the treatments by the physicians, we can conclude that patients with actinic keratoses should be treated with 5% fluorouracil cream, and probably these other treatments can be abandoned or be designated second-line treatments. The review in the New England Journal concerns CRISPR-Cas, and CRISPR-Cas is an incredibly important development in terms of genome editing. You might ask, where does this come from and what do these things mean? CRISPR is abbreviation for clustered, regularly interspersed, short palindromic repeats. Now that's a mouthful. These are DNA sequences with spacers in between them, and palindromes are DNA sequences that read the same in both directions. Like, for instance, the name Otto, you can read it from right to left or left to right, same alphabetical letters appear. And here we're talking about DNA sequences reading the same from right to left. So those are clustered, regularly interspaced, short palindromic repeats. Now, one thing about bacteria is they have problems with viruses just like we do. And in order to protect themselves from bacteriophage, looking like these little parachutes that sit down on these poor bacteria, that then squirt their DNA into these bacteria, what the bacteria do is they have enzymes that can cut the phage DNA. These are endonucleases in principle. They're abbreviated Cas, and there are a whole host of these. They cut this DNA, and then they stick this DNA into their own genome at CRISPR regions. And then the next time the phage comes along and squirts its DNA into this, then the bacteria use this transcript from this embedded segment within their own genome, attach it to a Cas enzyme, which then snips the phage DNA and stops the infection for the benefit of the bacteria. And this dramatic state of affairs was discovered about 10 years ago, and the investigators looking at this thought, well, this looks pretty interesting. These endonucleases that can snip DNA segments and the ability to stick DNA segments into certain portions of the genome, maybe we can apply this technology to human cells. And that indeed is what was done. And you can look at this YouTube cartoon that explains all of this far better than I can. So what was done here in human cells is using these enzymes, these Cas enzymes, CRISPR cutting enzymes, to cut the human DNA sequence at specific areas that are done by a sensor segment, and then using either homologous directed repair to put the ends back together, or non-homologous end joining, a technique that allows you to conduct the repair or even stick large portions of DNA sequences into these two ends to conduct genome editing. So with that as background, this review in the New England Journal concerns genome editing. And there are various approaches to this. Already before the millennium, zinc finger nucleases were engineered, much more tedious, and then other techniques were devised that looked promising. But now CRISPR-Cas9 technology has turned all of this on its head. So in this review in the New England Journal, this time sequence of events, this is where we are now, 2019, indicates that now these technologies are being used therapeutically to treat human disease. And in this review, how these things are done and how they developed are discussed. So in the 30 years ago, we could already find recognition sites, and with some endonucleases available then, cleave DNA at certain locations. But then with transcription activator-like effector nuclease dimers, these are called talons. It was possible to delete certain segments of DNA, and with zinc finger nucleases, this technology improved further. And with Cas9 endonucleases, with a specific RNA guide that can be attached to the endonuclease, targeted sequences can be deleted, cut, additional sequences can be inserted, and a whole lot of important things can be done. So this technology is reviewed. The Cas9 enzyme comes from Streptococcus pyogenes that you'll remember from bacterial pharyngitis. So these streptococci seem to be good for something. At least that's where the Cas9 comes from. Then the sequencing guidance RNAs to send these Cas enzymes to where we want them. And genome editing through non-homologous end joining allows us to insert sequences within the genome to meet our ends. And there are a whole number of studies going on with this that you can imagine. One technology would be to remove, in AIDS patients, remove progenitor cells, bone marrow progenitor cells, cut this cytokine receptor CCR5 out of them so HIV can no longer invade these cells, and then give the same cells back to these patients so that they have a population of T cells that are resistant to invasion by HIV. Or a similar technology to fix the mutation in the beta chain that results in sickle cell anemia, or to fix stop codons that interfere with beta chain synthesis at all and beta thalassemia. Whole variety of things can be done. As a matter of fact, similar things have already been done to work on the T cell receptor with zinc finger nucleases. And we've talked about CAR T cell therapies for a whole host of things. But with CRISPR-Cas technology, all of this can be done much better. So this technology brings forth a whole host of ethical considerations, and there are committees to deal with this problem in the United States and obviously also in Europe and worldwide. And while some of these committees, learned committees, were discussing these things, an investigator in China, a certain Dr. He, claims to have knocked out CCR5 in 2 developing twins, and he was then branded a rogue researcher, Schurke in German, because none of this was approved by any ethical committee. And also the idea of taking the person's own cells to remove CCR5 was not what was putatively done here. I'd like to point out that Dr. He didn't show any evidence that he had actually accomplished knocking out CCR5. And so all this may be a tempest in a teapot, but that's the state of news affairs on that issue. Now, the review in the New England Journal was a topic that I'd learned about in medical school, but hadn't really paid any attention to. And that's an uncommon disease called alveolar proteinosis. This is a pulmonary disease where all the alveoli are filled with a proteinaceous material. We knew that in 1964. We also knew that actually this was described in the 1950s. This material is strongly periodic acid Schiff or PAS positive, and these poor patients died of hypoxemia. And so what I was interested in learning is that there's been a substantial amount of improvement in terms of what we know about this rare disease. Some of these things seem to be genetically determined, but others seem to be acquired, and of course there were no treatments. So the patient of the week is a 42-year-old man who's a smoker. Pulmonary alveolar proteinosis is indeed more common in smokers than in non-smokers. He shows up short of breath and with a productive cough. and chest x-ray is done, and subsequently a CT is done. And what we see here is marked consolidation bilaterally of all the alveoli. We call this a ground glass appearance. Now, the patient was treated with vancomycin, ceftriaxone, prednisone, and he didn't get any better. As a matter of fact, then he loses a bunch of weight. And on physical examination, he has RALs bilaterally, as we can imagine. And as time goes on, the medications didn't help him, but we see here that on 100% oxygen, this patient had an alveolar to arterial gradient of 600 millimeters of mercury difference of PA large AO2 compared to PA small AO2. And if you've forgotten the alveolar gas equation, send me an email and I'll explain it to you. But at any rate, that explains why this patient's so severe hypoxemic, because on room air, because on 100% O2, he has a PaO2 of 55 millimeters of mercury, whereas he ought to have one of 600. So here's his CT, and what we see here is he has these are called bronchograms. The bronchi are filled with air, but the alveoli are not. That's why we can see them. Otherwise, we wouldn't be able to see these bronchi. And eventually, alveolar lavage is done, which in this case generally is helpful, but this patient, the diagnosis eventually was made by lung biopsy. And what we see here in these histological sections is that the alveoli are filled with all this red stuff here, and it's strongly PAS positive as shown here. Now, what I learned from this little article is that this protein is surfactant. And these patients produce surfactant, but they don't catabolize surfactant, so that basically these alveoli fill up with superfluous surfactant. What I didn't know is that GM-CSF, which I thought is involved solely with granulocyte proliferation and maturation, also influences type 2 pneumocytes, so that these cells develop properly, and these are the cells that are responsible for catabolizing surfactant, and if they can't work properly, then these patients get into difficulty. So GM-CSF stimulates the maturation of alveolar macrophages. I said pneumocytes, that's false, which are pivotal to surfactant catabolism. Now, it turns out that this rare condition is generally autoimmune, and patients, oh God, what is this? Sorry, I'll have to fire this up again now. Now, pause. I'll get it going. Be patient with me. So that works. Off-cycle still works. So 90% of these patients have an autoimmune disease where they make antibodies against GM-CSF. In some cases, there are genetic causes of this problem, but since this condition involves GM-CSF, GM-CSF, at least in knockout mice, might be an appropriate treatment for this problem. And as a matter of fact, our patient received additional GM-CSF, and his condition got some better. Now, 2 weeks ago, we talked about donut lesions in patients that have streptococcal pharyngitis. And indeed, this is the patient again. Still think this is chewing gum here. You better not chew that stuff in Singapore. Here's his pharynx, and these are these so-called donut lesions. And indeed, he had a rapid antigen detection test for group A streptococcus, and that was positive. Then there's this small patient in the New England Journal that shows up after a trip to Africa with these eschars. And I would probably also interpret these as possibly some sort of infected insect bites, but a closer look at them, This is typical for what is called African tick bite fever. This is actually a rickettsial disease. Apparently not as systemic as Rocky Mountain spotted fever, which is caused by tick bites in the United States, but with doxycycline, this condition improves. Then here's a question for you. A 62-year-old man who has poorly controlled hypertension, he gets hydrochlorothiazide, also requires simvastatin, 40 milligrams daily, which is a fairly high dose of simvastatin. Since his blood pressure is poorly controlled, the question is, what's next? And what you need to know to answer this question is that some of these drugs interfere with the catabolism of simvastatin and might result in myopathy. And if we look at that, simvastatin users, ketoconazole, erythromycin, protease inhibitors, gemfibrozole, cyclosporin, and danazole are on the list. But verapamil, diltiazem, amiodarone, and other drugs also can interfere with levels of simvastatin, but ramipril ACE inhibitors don't seem to do that. Then in the Lancet, which stent is best? And this study involves sirolimus-eluting coronary stents that are either have ultra-thin struts or compared to standard care stents. So it's Superflex against Zions. And the hypothesis here is that the new stent is no worse than the old stent. And so we look at the incredible large numbers of patients here, 720 in one group, 715 in another. Of course, they smoke a lot, and they have diabetes, and they have hypertension, and they have hypercholesterolemia, etc. And the randomization worked fairly appropriately. And if we look at this, well, what can we say here? The stents look about the same. That was the hypothesis. What bothered me a little bit is cardiac death. I mean, the differences here are less than 1%. Cardiac death looks a little better in the old stent than the new stent, whereas the clinically indicated target lesion revascularization looks a little better in the new stent than the old stent. But these numbers are too small to ascertain statistical significance. So the manufacturers of the new stent were very much excited in that their product was no worse than the old stent. Then the next topic involves treating patients with acute stroke in terms of thrombectomy. And there are several devices that are possible here. One of them is an aspiration device where you shove this catheter up against the thrombus, pass a wire through the thrombus, and then try to remove the thrombus with this mechanical device shown here. An alternative strategy is to put a wire through the thrombus, then move the catheter through the thrombus, and then squish the thrombus against the wall by putting in a stent retriever. I know little about the technical aspects of this, but basically what was done here is aspiration thrombectomy was compared to stent retriever strategy. And you'll be happy to know that a fairly large number of acute stroke patients that are eligible for this therapy, but it looks like the two products were similar in terms of outcome, and we can rest assured that whatever the operator can has the most experience with is probably the best way to go for this treatment. The third study in the Lancet involves using transdermal nitroglycerin or glyceryl trinitrate in patients with acute stroke. Seems like a good idea, harmless enough. Maybe it might help these patients a little bit by lowering their blood pressure or some other salubrious effect. So this strategy was tried in fairly large numbers of patients here, and the randomization seemed to work. And in terms of a whole host of endpoints that were hospital stay and discharge date and hospital admissions and readmissions, etc., death at 90 days, and particularly important, this Rankin score, doesn't seem to indicate that using transdermal nitroglycerin helps patients with acute thrombotic stroke. Another stroke study involves in this case, not thrombotic stroke, but intracerebral hemorrhaage. Now, if the hemorrhage is above the tentorium cerebelli, we don't know exactly what to do. Craniotomy and a hematoma evacuation was not shown to exhibit any sort of benefit, but perhaps using microinvasive catheter evacuation followed by thrombolysis of the remaining clotted material, abbreviated MISTY, might be helpful. So hope springs eternal, so this strategy was tried in patients with cerebral hemorrhage. And again, the randomization seemed to work effectively in both kinds of treatment. And if we look at this forest plot, unfortunately, there's no difference, although it looks like MISTY might be a little better than standard care, but these things were not statistically significant. Although it was pretty close, maybe, don't know for certain, P is less than 0.037. These Rankin scores are not that impressive, but maybe doing MISTY is a reasonable thing to do. So a lot of discussion, evidence before this study, and added value and implication, and the authors couldn't quite decide if MISTY can be recommended routinely or not, but some patients might be helped. There are important reviews in the Lancet. One of them is on the big issue here is heart failure. And I was interested to observe that heart failure isn't really very well defined in this review. But basically, what we're dealing with is hearts that are not able to deliver the required amount of blood that the body needs without an elevation in filling pressures. And the definition of these things in any language, be it English or German, is somewhat less than precise, but that's how I would define it. So we can look at the New York Heart Association classification. And if you've forgotten a little bit about what that's about, clinical classification in terms of what the patients are actually able to do, and how this condition presents, and the difference between heart failure with preserved ejection fraction and heart failure. We used to call that diastolic heart failure, which I thought was a pretty good term, but the cardiologists want something different compared to heart failure with reduced ejection fractions. And if we look at the clinical trials for heart failure with preserved ejection fraction, thus far, nothing has been helpful. But hope springs eternal, and I noticed that SGLT2 inhibitors are being tried for heart failure with preserved ejection fraction, even in patients that don't have diabetes, which I think is rather interesting. And spironolactone, I thought spironolactone was dead, but there are several spironolactone trials still pending. And then there are some new treatments for heart failure with reduced ejection fractions. And again, SGLT2 inhibitors that are actually drugs to treat diabetes are on the list. And omecamtiv, which is this cardiac-specific myosin activator, is also being tried. Then there are some more modern treatments here that I'm not familiar with, but you can review this. Anakinra is here on the list, complement, interleukin, etc. Even febuxostat, a xanthine oxidase inhibitor, a variety of things are being tried. Then there are also treatments for heart failure that are either mechanical treatments or cell-based treatments rather than drug-based treatments, and these are reviewed in the next review. And the theoretical considerations concerning these treatments is reviewed. Cardiac resynchronization is certainly indicated in patients with left ventricular bundle branch block, and if they have sinus rhythm, this is helpful. Inducing an atrial septal defect, I would think, is probably a bad idea, but even that is a transcatheter intra-atrial shunt device to reduce filling pressures in the left atrium is being tried. And then a whole number of cell-based therapies. Since a series of papers have recently been retracted involving cell-based therapies because of fraud, these ideas are difficult to evaluate. And the last review in the Lancet on heart failure is on imaging. And there's a whole host of things that have happened here in terms of making diagnoses, including further developments in not only PET-CT, but MRCT to identify ischemic areas and multimodality assessment of myocardial viability. Sounds reasonable. Ultrasound has made amazing strides, not just in Doppler evaluations, but also in reconstructing three-dimensional pictures of what valves look like on the basis of ultrasound examinations. Lovely pictures in these reviews, and you should look at them. We're almost done. I was interested in this paper in JMA, and it concerns which doctors have the sickest patients. And what was done in Canada is where a health care system is conducted where the patients are monitored with electronic medical record systems. The complexity of the patients seen by different types of physicians was reviewed. You might think that the doctors that are taking care of the most complex patients, maybe they should receive more money or at least get a pat on the back. So that was, so comorbidities, and these are all coded in these electronic health record systems, and physicians' care and how commonly the patients came to the hospital or to the clinic or whatever have you, and the various subspecialties were looked at. 9 markers of complexity were here reviewed. And what we see here is the patient type, the doctor type, seeing the most complex patients is listed here on the left. And the nephrologists win hands down. The infectious disease specialists are in second place, probably because of HIV patients. Then come neurologists, pulmonary physicians, hematologists, oncologists, rheumatologists, etc. Cardiologists are down there because they only deal with one organ. Dermatologists have a pretty easy life, and family physicians do too. So here's the graphic information. Comorbidities, nephrologists are up there. Risk of mental health conditions. Here the infectious disease specialists are up there. Prescribed medications, nephrologists again are on the top. So the nephrologist's lot is not a happy one. Here all this is displayed graphically, complexity rankings by physician type. So the points are that there are differences between specialties, and I think this is important because the amount of applicants for nephrology training programs has decreased dramatically in the United States and also in Europe. And if you ask the house staff and the medical students, why don't you want to become a nephrologist? They'll tell you, I don't want to work that hard. We're going to close with this case that was published in Nature. And it concerns, again, HIV remission by knocking out CCR5. And I thought, from looking at the headlines in Der Spiegel and in Frankfurter Allgemeine Zeitung or in the New York Times, I thought this would be a CRISPR-Cas9 based strategy. But it's actually the same as in the famous Berlin patient from 10 years ago. This is an HIV patient that developed Hodgkin's lymphoma and required a bone marrow transplant. So they found him a donor that through a germline mutation doesn't make CCR5. And they gave him this new bone marrow that doesn't contain CCR5, and he got quite a bit better, and after 18 months they were able to discontinue his HIV drugs. But I think CRISPR-Cas9 will be better. With that, thank you for your attention, and if you want to hear the same business in German in 5 minutes, stick around. Thank you.